But given the way government continuously views doctors as potential criminals or even, part of the crime, and slaps such very strong punitive measures if the reporting is not done immediately in time, I don't see any other way out of that. I leave it to this august audience to decide on this issue, and probably those of you who have access to the higher echelons of government, maybe you need to take up this topic once again, that there should be some time frame in which the psychiatrist or the psychologist should be able to talk to the child over a long period of time, get them ready to report, and then actually take this case to police and court. Muskan is doing phenomenal work. So in Pune, life has become a lot more easy. I can refer the child to Muskan after a certain amount of time, and they handle all of this in child-friendly way. But in most other cities, except Mumbai and Pune, we are still in a very, very tricky situation. Thank you.
My question is for Dr. Suchita Agarwal. I had the opportunity of meeting Dr. Klaus Beer, who is a German psychiatrist who is famous in the treatment of pedophilia. He had come to India and he's got a branch in KEM Hospital where Dr. Suchita Agarwal is working. I changed my perspective of pedophilia after listening to his talk. And there he said it's a neurodevelopmental disorder, and he described some cognitive behavior therapies where he has got success, so much success that the German government is funding his project, and people who are having pedophilia and pedophilic urges are being given insurance to attend therapy sessions, which are quite expensive. And he convinced the audience to a great deal that instead of this punitive measures of catching the culprit, death sentence, putting him in jail, all these legal procedures, and we waste so much money in that, rather we could use the same money in the prevention of pedophilic acts. And he started that Don't Offend. And in India we have one of the strictest POCSO laws in the world. And because of that, people are scared to come for therapy. Especially even those who have not committed an act, just with an urge, with an orientation. So I would like your views on that. And what was the treatment he gives? And I know you are in some way, you need not tell us all the details of the research, but you are involved in the research process. So could you please tell us on that? I'm sorry if my question was a bit long, but it was to give you the background.
Thank you so much for the background. And also, I would say Dr. Advocate Rama Sarodi Madam has also laid down a background where she has spoken about, we always focus on the child. And when we are talking about POCSO, it comes into effect only after an offense or a crime has been committed. So what Dr. Klaus Beer started in Germany in 2005 was to focus on potential offenders. So what he found was in cases of child sexual abuse, about 40% of the abuse was committed by those who had pedophilia. And 60% is not by pedophilic people. It is for some reason they use the child as a substitute to fulfill their sexual urges. So firstly, again, to differentiate pedophilia from child sexual abuse, only 40% comes from pedophilic disorder. But what he also found was the rate of recidivism, that is repeat offenses, is much higher in those with pedophilia. So they are more likely, about 60 to 70% more likely to reoffend. And those who don't have pedophilia are only about 10 to 15% likely to reoffend. So he started with that in 2005, and like Sir rightly pointed out, initial funding was by various organizations, and then the government took it up. So it's running very smoothly there. He approached KEM Hospital Research Center in 2015, and the project was taken up. It's a very bold step to do in India, considering we have such a strict law. So what we did was we adapted it a little bit. We said, okay, we cannot treat those who have already offended, because that will just jeopardize the whole project, where people who have offended will approach us, and every time we just have to be involved with the legal authorities. So we picked it up and we said we'll treat non-offending pedophiles. So the motto here is treatment of self-identified, non-offending, and those who are motivated to abstain from ever offending a child. These people are taken up for treatment. Now about treatment modalities that we use. So yes, just like any other psychiatric disorder, psychological, pharmacological, and here an added aspect of sexological approaches are used. They're all based on well-researched integrative models of preventing recidivism. So they're picked up from various different countries, various programs that are already running for sexual offenses in general, which he adapted for child sexual offenses and treatment of pedophilia. So CBT, very basic, what we know about. Good Lives model is something that is used. Then relapse prevention is used. So some people might just be doing very small acts, like, just fantasizing about children while masturbating, or, sometimes they'll watch cartoon porn or something like that. So I don't know. I mean, madam would be able to advise if that is also something that is criminal, because there is no child involved, but yes. So these kind of minor offenses also we discourage them. Then risk need responsibility model is used, acceptance commitment therapy is used. So all this over a period of time. Of course, initially there is detailed assessment. We try and involve family members. So most important risk factor is not having social support. So it's very important, and in many cases the experience has been positive. The partners are accepting. Many of them are married. Okay, so how are they married would be a question again. So not everybody who has pedophilia is exclusively pedophile. So they may have attraction not just towards children, but also towards older aged people. It can be mainly towards females, mainly towards males, or to both the genders. So they may be married, they may even have children, they may be living amongst us and we don't know. So like again, what madam pointed out was 98% of, 98.98% of child sexual abuse happens by people who are known to the victim. So there are people who are very easily part of the society, but there are also people who have never offended, those who have exclusive pedophilia. They're living their lives, they don't want to offend. So they come to the project, they say, I'm scared that something might happen, I might do something, so help me, how do I not do something? So the main aim is to integrate that sexual preference into their identity, and then, proceed with the therapy, the various ways, their individual risk factors, what are their needs, how do we respond and cater to the different populations of pedophiles. So each person who has pedophilia is also going to be unique in their own social situation. So main thing, again, reducing the risk. The risk of offending needs to be taken into consideration, and if any of you, I would really urge, if you come across somebody or if you suspect that somebody is trying to tell you that, they, or even trying to open up about their sexual orientation, please encourage them. This is the way that you can prevent sexual abuse. And even one person, even one sexual abuse prevented is a huge, huge deal. It's a huge deal in terms of emotional cost, social cost, economic cost, everything. So I would really urge that. And also I would urge you to make yourself familiar with what are the ways that there are a lot of resources available. If somebody wants, I can provide them. A lot of resources to educate yourself. There is also a training program that runs under Dr. Klaus Bayer, directly taught by German therapists. So anybody who is interested can enroll. They have very limited availability, but every year it runs. So right now they've made it available outside also. Earlier it was they were doing the therapy and only KEM, but now they're allowing other people to take part. So sorry if my answer was a little bit longer. Thank you so much.
My next question is to Ms. Jyoti Singh. Firstly, congratulations for the work you're doing with Muskan, the NGO, and I think all of Pune is grateful that there is such a thing which is available, which is not there in so many other bigger cities. And that makes a difference. So my question to you is, how does it make a difference? Firstly, what are the short-term and long-term options that you exercise for the victims by way of therapy and beyond? And finally, what do you do by way of prevention? Prevention is a topic very close to my heart.
Yes, I reiterate that, and I am very proud and humbled to be part of Muskan team. So as far as the short-term and long-term goals, very often they overlap, because we don't have some of these children for very long. But our primary focus, there have been a lot of children who have been there for a long time, but primarily after the first few weeks is done. But because we finger hold them from disclosure to conviction, there is a sense of dependency which kind of builds up with Muskan, because of which they do come in for counseling. So our whole impetus is a parallel model of pharmacology and counseling which is there. We try to revolve around the model of trauma-focused CBT. And because of the infrastructure, because of the time availability, because of their support, sometimes keeping to the complete model might not be possible, but we do keep to the basic structure of it. So we begin with psychoeducation, because the passive trauma victims, the parents or the primary caretakers who've been part of this, are the ones who at this point are going to be the main people in helping the child limp back. So simultaneously there's psychoeducation for the parents or the guardians, as well as for the children, because they need to know what is going to follow now. They need to know when else they need to talk about this narration again. They need to know safety barriers, how they are safe at this point. Then it is the entire CBT model takes in, where the reprocessing of the traumatic thoughts which are there. A lot of them have feelings of guilt. A lot of them have feelings of fright, because the perpetrator has various ways in grooming them and in frightening them. So to help reprocess that and remove the fears and the related traumatic feelings which are there. This could take somewhere, this takes the longest period of time. There have been instances where during this re-narration, they have kind of gone back and they've shown a lot of symptoms of trauma again. And this is where a lot of expressive therapies are used, where we found art and play therapy, as Dr. Shetty also mentioned, have been of a large help to a great extent. In fact, art therapy has helped even more than the play therapy. There are a couple of occasions where they have been indulged in other activities in a group which is there, but primarily the focus is one-on-one. As the process goes on with the narration, then we come on to the cathartic part of it, teaching them relaxation techniques as and when the memories, the trauma-based memories come up. Then there is family therapy, where together we have with the caretakers and the children. What happens sometimes during this process, especially during the family therapy part of it, is that the child has made progress, but the caretaker has not. And because of that, very often, individual work then with the primary caretaker needs to be done. Because the younger the child, the easier it is for the child, to kind of get back into normal life. With older children, with teenagers, they need to be finger held for a much longer time, especially during their relationship issues. And it's very heartening sometimes to look back on a 10-year, 12-year track record and see some of our CSA victims doing very well in life today. Some of them we've lost track with, some of them have successfully got convicted. So there's automatically a sense of healing which takes place with conviction. And sometimes we've lost cases are still pending, and those are the ones where it's more difficult to help through this process. But essentially this trauma-focused CBT ends with regular follow-ups, regular assessments, and the assessments cover not only the socio-emotional aspects but the cognitive aspects also. Because of trauma, very often school grades and academic performances have also dropped. So side by side, helping them to continue with regular life and seeing wherever the hiccups are, basing those. And my second question, do I have time for that? What does Muskan do?
Yes, and prevention.
Yes. So awareness is what Muskan has been doing hugely, and this is in the rural areas as well as the urban areas, all age groups, targeting right from schools to societies to parents to hospitals. And this huge project which is going on now is the coordinated training of police personnel on how to handle CSA cases, how to help detecting these kind of cases. Also working with the children in the observation homes, so that the ones who are already there and the ones who are about to leave, and then follow up with those. That is also there. There's a lot of audio-visual aids which have been made, which are screened very often. There are short stories, there are clippets which have been made. There's a lot of POXO training which happens on a continuous basis. And I think the most important thing that Muskan does, and that's how I got into it, because every time I would have a CSA case, it would be, I would know that there is a Muskan there to take over a lot of the things. So actually being there right till conviction is something which I have seen Muskan do relentlessly. The social workers and the counselors there are called at 2 a.m. to the police station, sometimes to help with disclosures, and they are there. So it just gives this huge sense of buffer, knowing that with these kind of cases which get swept under the carpet because it still causes ostracization of the client, it's not encouraged. But the minute you know that, look, I'm going to give you the number of Muskan, they'll help you. There's much more reporting which has started happening. So that's where they contribute.
Thank you. So now it's open to the audience. So you have this very learned panel whom you can ask your questions to. If there are any questions. Yes, please. Yeah. Can we reach a mic across to the...
I also want to ask a question. Myself, Dr. Nikhil Kanse.
You can come and give her a chance.
A very good evening to all. At the outset, I would like to thank the panelists for a very good deliberation on the very sensitive issue. I'm Colonel Dapple, an Associate Professor from College of Nursing, Armed Forces Medical College. Regarding this particular issue that we have just discussed, we know it's sensitive. However, my question is literally for you, advocate, ma'am. You said that penalty is not the ultimate option. However, we know how sensitive such cases are, whereby not only in India but many countries, cases are still not reported. I quote Ma'am Jyoti as she had said, and we all know about that. And in our country, we have been speaking about how we have been able to help cases where acts have already been committed. Now, if that penalty is not an option, and in a country like us where the act is very stringent, like sir has also quoted, what would be an alternative so that justice is being delivered? And at the same time, what are those preventive measures you had in mind so that you can share with us healthcare professionals, that we will be able to educate society and at large be able to prevent such cases from happening, so that the public would have some fear about what is going to happen? Thank you.
the option in cases of sexual violence because you cannot equate it to murder. Earlier, we did have very stringent punishment where it went up to life. And life imprisonment is not 14 years as we understand. It is for the entire life of that person. So I have worked in the prisons. I have worked with prisoners, and they would rather prefer a death penalty than an imprisonment for life. It's even more painful. So I think that is the way out. Also, there have been cases, there was one case that we have dealt with where this man was convicted for an offense of life at that point of time for raping and murdering a little child, 10-year-old girl. And later on, after 11 and a half years, we realized that it was a false case against him and he was a rag picker sleeping on the pavement of Mumbai. And he was just picked up from there. Evidences were created. There was his semen was put over on the clothes of the girl. That was and created evidence. And then he was arrested and he was in the prison for 11 and a half years. At that point of time, we didn't represent people who were accused of rape because that's a choice we made as lawyers. But because there was consistently telling us to listen to his case, and we did listen, and after 11 and a half years, we helped him come out of the prison. And we got to know this because the investigating officer committed suicide because he couldn't take it upon his conscience that he had to fall to the pressures of his seniors and get a man who was innocent to be convicted in a crime like this. Now, we were able to save this man after 11 and a half years because it was not a death penalty. If it had been a death penalty, he didn't have any means to go in appeal up to the Supreme Court or even the High Court for that matter. He was languishing in the prison right after the session court trial. So life imprisonment is an alternative to death penalty, but more than that, I think it's about how the systems work. More than that, it is about how the investigation happens. More than that, it is about the disclosure that Yajoti talked about. How are we presenting the charge sheet in the court for a conviction to happen? How certain can we be that a person who has committed a crime and the right person is convicted in that offense? We have come across a lot of cases where unless and until there's an ownership from the person who are reporting the case, especially children, unless and until there is a ownership, there is pressure put on them. They're taken to some other place, they are married off there, and that's how we've seen failures in some cases where it doesn't reach to a conviction also, because they are not allowed to come before the court to depose before the court. So there are a lot of loopholes in this law, and we need to ensure how all these systems work well. Now, when we say that the police is not supposed to question the child, in a uniform, in the police station, the child is allowed to have somebody that they feel comfortable with, when the questioning is happening. Yet we see that the police is just changing the shirt, still keeping the khaki pants, still keeping those uniform shoes, and going on the white bike that has police written to the child's house to ask questions, where the entire community gets to know that there's a police who's coming and interrogating, which means that the disclosure or that does not have the confidentiality of the case to see that the name of the child does not come out as a victim in a case of child sexual abuse is lost. So these are the minor loopholes that we don't pay attention to, which kind of blots the whole investigation process and the way it is happening. The time taken for investigation is another hurdle because of which there is no conviction happening or the conviction rate is very low. So I think if we don't kind of work on these loopholes that are there in how the investigation is happening and how the procedure to ensure that a conviction happens is happening, we will not be able to get that conviction rate whether you have a death penalty or whether you don't have a death penalty. The other deterrent is that with a death penalty, people will not disclose and report cases done by their close relatives and people whom they are known to. And that is one reason why there is low reporting. So we need to work on these factors, and we need to work on the preventive factors more than just saying that it's death penalty that will bring down the crime rate. It will not bring down. We have evidence, we have data now to say that it has not brought down.
Exactly. Next, please. Yeah, please go ahead.
My name is Dr. Nikhil Kanse. I want to share a case. Incidents happened in my rehab center. One 16-year-old girl child admitted for polysubstance dependence, and she over the treatment time she claimed that one of your brother staff member had sexually abused me and and raped me. After some inquiry done in the ward, so other female patients were denying these incidents. In such a situation, how to proceed? And one more thing I want to ask, in similar kind of situation, if parents and patient they disappear after informing to the parents, and what to do if police authorities are not taking this case and refusing to take this case? How to proceed in these three situations?
Ma'am, I think you would be best qualified to, address this.
Yeah,
and
sure.
Of course,
So,
if you have any experience with cases like
the first question about what happens, to somebody, a staff has, you narrated a case where a staff has abused the girl. The first thing to do is if she wants to report it, it has to be filed as an FIR with the police, and then, of course, with a case of sexual abuse, I'm sure you're all aware that she has to go through the medical examination, and the medical examination may give some evidences, and because the medical examination is not just for superficial marks, but gynecological, psychological, all those examinations happen, and that's how the investigation would start. But the first thing is to report the case, even for us to know who did it, or rather, if she knows already who did it, then ask her to disclose who it is. Sometimes she may not know the name, so who were the people who have interacted with her or have a possibility of interacting with her, and that's how probably you will have to find out to get a disclosure of who has done it. And your second question is about what if the police don't take the case. If you want to report the case and if they don't take the case, there are ways to escalate it to the next level. So I would say that such a case, a serious case, there's already said that a particular ranking officer has to investigate in matters like this. Though the police don't like that kind of a distinction, but that's the truth, it's part of the law. So when they don't do it, you escalate it to the next level, and you can always send it to them in writing, or you go to them and give a copy of the complaint and get an acknowledged copy with you, and if they are not taking any action, you can always use the Right to Information Act to ask them what's happening with this case. And of course, there's escalation that can happen right up to the commissioner level. So that's how you do. And if nothing else, I would say that Muskan really has a good rapport with all these stakeholders. Get help from an organization like Muskan, because they are focused and working only on issues of child sexual abuse from all angles.
Would you like to add something to that, please?
Just to add, I think here the fact that there is a bit of doubt is being conveyed to her also. So number one, why the doubt? She needs to be given the benefit, So at this point, the detailed disclosure procedure, because it's not happening in a police station, it can be done in a very comfortable setting where there are ways of getting the disclosure done through projection, where it's easier to actually find out in sequence what probably could have happened, and that becomes your base then for the investigation also to start off. You also mentioned that the others did not agree with it. Why do they come into the picture yet? They will come into the picture afterwards. So the whole impetus right now is on the disclosure and your trust in her, because below 18, the entire domain and premises, you need to trust the child first, and then probably proven, not true.
One small question for Dr. Jyoti Singh. As you heard the clip from Dr. Bhushan Shukla, he said that the best child-friendly procedure is one interview. And you ask, I mean, I'm not saying you're contradicting him, but you say that disclosure is a whole series, a process which takes time. So how do we reconcile the two, not causing trauma to the child, at the same time getting the investigation done?
It depends on why the disclosure has not happened the first time. If there is a good setting for disclosure, even a 4-year-old's first disclosure is the most authentic because there have been no contamination. But because there have been a lot of contaminants which have happened because partial disclosure has already happened, that is where it goes in a series of things, where police are already involved and where they have already written out an FIR, they've already given clauses. Very often after proper disclosure, the clauses are changed. But then for the child to come to that point and for them to believe that, okay, no, I think we can add one more clause. Maybe, yes, this has happened. Because initially when partial disclosures happen, I mean, it's probably work-wise, it's like, okay, we've got the CSA, we've got the thing. But unless the specific details are there, the right kind of clause will not be put. So therefore, if there is a doubt, if the child has speech issues, if the child has IQ problems, if we are using purely expressive projective therapies, then we need more than one. But if a case like this, if her IQ is intact, and if there are no other psychological concerns which are there, then a one-time disclosure can help to a large extent.
Yes, ma'am. Yeah, I just wanted to add, I think because he's from an institute, and as I said, we admit patients if it's a closed ward setting, obviously without relatives, and as you said, it's a minor with polysubstance use. So when you know that this is a sort of clientele that you will be admitting, I mean, why I even addressed that issue of SOPs was for this reason, that, the way we see patients, the way they are handled by patients, as Madam was saying about the contamination because of repeated disclosure, the first thing that we can do in prevention is actually lay down the rules and educate all your staff, medical and paramedical and non-medical, as to what is the reason that you're doing this. So, everyone puts CCTV cameras everywhere, but even educating them, I mean, this can extend to anything. It can extend to even sexual harassment. It's both for the safety of the patients and all the stakeholders, including the caregivers and the medical staff that are involved. So I think it's good to have that and also put it there, so that even patients know that this is the type of institute I'm getting into, right? Yeah. Thank you.
Okay. So with that, we come to the end of today's last panel discussion on POCSO Act, and I am sure you will agree that it has been a very enlightening discussion from various psychiatric, social work, psychological and legal perspectives, and people who are actually doing real work related to POCSO. So I am sure there are many more questions, but we know that there are many channels also where we can work in the field, and it will help in our clinical practice if we have to deal with CSA. So I would like to thank all the panelists for their wonderful views and enlightening us, and I also would like to thank on my end Dr. Kaushik sir's behalf, Dr. Netto sir, for organizing such a wonderful symposium and this panel discussion. And it's a privilege to be here on BJMC dais. And kudos to the entire organizing team of BJMC Department of Psychiatry. Thank you so much. Have a wonderful evening.
Thank you, ma'am. I once again thank all our esteemed panelists for this insightful discussion. We shall now proceed with the felicitation. I'd like to mention here again that the artwork on the bags being presented is done by the patients attending the psychiatry OPD at the Department of Psychiatry, BJGMC and Maharashtra Institute of Mental Health, Pune. I request Surgeon Commodore Kaushik Chatterjee to felicitate Dr. Jyoti Shetty. I request Dr. Smita Panse to felicitate Dr. Suchita Agrawal. I request Dr. Ivan Netto to felicitate Dr. Yajoti Singh. I request Dr. Smita Panse to felicitate Advocate Rama Sarode. Moving on to the felicitation of our moderators, I request Dr. Nitin Abhiwan to felicitate Surgeon Commodore Kaushik Chatterjee. I request Dr. Krishna Kadam to felicitate Dr. Smita Panse. I request Dr. Nishikant Thorat to felicitate Dr. Ivan Netto. We have thus come to the end of this conference. It needs the help of one and many to put together an event of this magnitude, and the contribution of each must be acknowledged. To do the honors, I request Dr. Krishna Kadam to come on stage for the vote of thanks.
Hello, yes. Good evening all. It's nice to see so many people in the hall, even we have come to the end of this symposium. Already we are late by 30 minutes, but I will not take much time to convey my vote of thanks to all. This was 6th year we conducted a National Forensic Psychiatry Symposium. We started the activity under leadership of Dr. Ivan Netto in 2017. For first 3 years we conducted it in offline mode, and due to COVID we conducted in online mode for last 2 years, and then again this year we decided to conduct it in hybrid mode. So it was not an easy job for us actually, considering the paucity of manpower in the department, since new residents they are not yet joined, and also a few of our faculty members they are ill. So even then we went ahead with this event and program, and on the behalf of organizing committee of this National Forensic Psychiatry Symposium 2022, I want to express my gratitude who have greatly contributed or supported this symposium. We spent all last 3 months for preparation and organization of this event. And first of all, I would like to thank all government officials, Dr. Sadhna Tade, Dr. Ajay Chandanwale, who is Joint Director of DMER and who also happens to be Director of our institute, Maharashtra Institute of Mental Health. Then Dr. Vinay Kale, who is Dean of BJ Government Medical College. Also, after that, Dr. Mohan Agashe, first director of our institute, Maharashtra Institute of Mental Health, Dr. Mohan Agashe. I am thankful to him. Our two ex-presidents of Indian Psychiatric Society from Pune, Brigadier M.S.V.K. Raju and Dr. Vidyadhar Watve, they also came and they were present for the most of the part of this symposium. President of IPS Western Zonal Branch, Dr. Arun Marwale, he was present for the felicitation program also, and he was there for most of the time. And then again, online office bearers of Indian Psychiatric Society, Dr. N.N. Raju, Dr. Vinay Kumar, Dr. Arvind Brahma, Dr. Alim Siddiqui, and editor of Indian Journal of Psychiatry, Dr. Om Prakash Singh. He was also there as a panelist for the symposium. All panelists, moderators, they gave us new insights into the forensic psychiatry. And then most of all delegates who came in offline mode as well as online mode, there were more than 200 registrations for this symposium. It was a big thing for us. We did not expect, considering the festive season during these days. And most of all the MIMH faculty, right from our head of the department, then Netto sir, Dr. Nishikant Thorat, Dr. Avinash Karde, Dr. Ananya Dhar, and all senior residents and residents of our department, they were contributing to this event largely for last 2 or 3 months. I am thankful to them. And most of all, as usual, this symposium is occasion for us, those who have completed post-graduation in psychiatry from BJ Medical College. It's an occasion for us to, it is a kind of reunion for us. So I would say that there were 55 alumni from BJ Medical College Department of Psychiatry who were present today. It was a great occasion for us, and I expect next year when we may conduct this symposium at MIMH Pashan campus, we will have more number. Thank you. Thank you all of you.
I now request everyone to kindly rise for the national anthem. Thank you.